Optic neuritis is a demyelinating inflammation of the optic nerve. It is also known as optic papillitis, when the head of the optic nerve is involved, and retrobulbar neuritis, when the posterior part of the nerve is involved. It is most often associated with multiple sclerosis, and it may lead to complete or partial loss of vision in one or both eyes. Partial, transient vision loss, lasting less than 1 hour, can be an indication of early onset multiple sclerosis. Other possible diagnoses include diabetes mellitus, low phosphorus levels, or hyperkalemia. Signs and symptoms. Major symptoms are sudden loss of vision, partial or complete, sudden blurred or foggy vision, and pain on movement of the affected eye. Early symptoms that require investigation include symptoms from multiple sclerosis, twitching, lack of coordination, slurred speech, frequent episodes of partial vision loss or blurred vision, episodes of disturbed/blackened rather than blurry indicate moderate stage and require immediate medical attention to prevent further loss of vision. Other early symptoms are reduced night vision, photophobia, and red eyes. Many patients with optic neuritis may lose some of their color vision in the affected eye, especially red, with colors appearing subtly washed out compared to the other eye. Patients may also experience difficulties judging movement in depth, which can be particularly troublesome during driving or sport. Pulfrich effect. Likewise, transient worsening of vision with increase of body temperature, a Thoff's phenomenon, and glare disability are a frequent complaint. However, several case studies in children have demonstrated the absence of pain in more than half of cases, approximately 60%, in their pediatric study population, with the most common symptom reported simply as blurriness. Other remarkable differences between the presentation of adult optic neuritis as compared to pediatric cases include more often unilateral optic neuritis in adults, while children much predominantly present with bilateral involvement. On medical examination, the head of the optic nerve can easily be visualized by a slit lamp with high plus or by using direct ophthalmoscopy. However, frequently there is no abnormal appearance of the nerve head in optic neuritis. In cases of retrobulbar optic neuritis, though it may be swollen in some patients, anterior papillitis or more extensive optic neuritis. In many cases, only one eye is affected and patients may not be aware of the loss of color vision until they are asked to close or cover the healthy eye. Cause. The optic nerve comprises axons that emerge from the retina of the eye and carry visual information to the primary visual nuclei, most of which is relayed to the occipital cortex of the brain to be processed into vision. Inflammation of the optic nerve causes loss of vision, usually because of the swelling and destruction of the myelin sheath covering the optic nerve. The most common cause is multiple sclerosis or ischemic optic neuropathy, blood clot. Blood clot that supplies the optic nerve. Up to 50% of patients with MS will develop an episode of optic neuritis, and 20 to 30% of the time optic neuritis is the presenting sign of MS. The presence of demyelinating white matter lesions on brain MRI at the time of presentation of optic neuritis is the strongest predictor for developing clinically definite MS. Almost half of the patients with optic neuritis have white matter lesions consistent with multiple sclerosis. Some other common causes of optic neuritis include infection, e.g. tooth abscess in upper jaw, syphilis, Lyme disease, herpes zoster, autoimmune disorders, e.g. lupus, neurosarcoidosis, neuromyelitis optica, pinch in optic nerve, methanol poisoning, B12 deficiency and diabetes. Injury to the eye, which usually does not heal by itself. Less common causes are papilledema, brain tumor or abscess in occipital region, cerebral trauma or hemorrhage, meningitis, arachnoidal adhesions, sinus thrombosis, liver dysfunction or late-stage kidney. Demyelinating recurrent optic neuritis and non-demyelinating, CRION. The repetition of an idiopathic optic neuritis is considered a distinct clinical condition, and when it shows demyelination, it has been found to be associated to anti-MOG and AQP4 negative neuromyelitis optica. When an inflammatory recurrent optic neuritis is not demyelinating, it is called chronic relapsing inflammatory optic neuropathy, CRION. When it is anti-MOG related, it is demyelinating and it is considered inside the anti-MOG associated inflammatory demyelinating diseases. Treatment and prognosis. In most MS-associated optic neuritis, visual function spontaneously improves over 2-3 months, and there is evidence that corticosteroid treatment does not affect the long-term outcome. However, for optic neuritis that is not MS-associated, or atypical optic neuritis, the evidence is less clear and therefore the threshold for treatment with intravenous corticosteroids is lower. Intravenous corticosteroids also reduce the risk of developing MS in the following 2 years in patients with MRI lesions, but this effect disappears by the 3rd year of follow-up. Paradoxically, oral administration of corticosteroids in this situation may lead to more recurrent attacks than in non-treated patients, though oral steroids are generally prescribed after the intravenous course, to wean the patient off the medication. This effect of corticosteroids seems to be limited to optic neuritis and has not been observed in other diseases treated with corticosteroids. A Cochrane systematic review studied the effect of corticosteroids for treating people with acute optic neuritis. Specific corticosteroids studied included intravenous and oral methylprednisone, and oral prednisone. The authors conclude that current evidence does not show a benefit of either intravenous or oral corticosteroids for rate of recovery of vision, in terms of visual acuity, contrast sensitivity, or visual fields. Epidemiology. Optic neuritis typically affects young adults ranging from 18–45 years of age, with a mean age of 30–35 years. There is a strong female predominance. The annual incidence is approximately 5/100,000, with the prevalence estimated to be 115/100,000. Society and culture. In the Season 5 episode of Dr. Quinn, Medicine Woman, Season of Miracles, Reverend Timothy Johnson is struck blind by optic neuritis on Christmas Day, 1872. He remains blind for the duration of the series. In Charles Dickens' Bleak House, the main character, Esther Somerville, suffers from a transient episode of visual loss with symptoms also observed during the course of optic neuritis. Sir William Searle Holdsworth suggested Bleak House to have taken place in 1827.
Please subscribe and thanks for watching.